Finally, a talk that's not a bypass, or the best CLI. Complications, my favorite. My first drink. I qualify as an expert. I've screwed up enough cases. Hopefully less people. So, 74-year-old female, diabetic, bad kidneys, ischemic heart disease with a good EF, smoker, previous POBA and DCB and spot stent to the mid portion of the SFA for a small wound, and now presents with this. Pre-procedural imaging shows stenosis of the SFA. I'm not sure if it's around the stent. Looks pretty good. Heel gangrene is quite bad. 2 vessel runoff, AT, partial arch, peroneal going to the heel. Okay, 2017. What are your thoughts? What's the plan? Recurrent SFA pop stenosis, previous drug-coated balloon. Anybody for this? PK, you're always quiet. Come.
Well, no, I'm not quiet at all. I mean, in this recurrent SFA pop, and you said previous DCB, so
Yep.
and he's got a heel gangrene. So I think with the pressure head that's needed, I think I would probably refer if he was a bypass candidate for a bypass, just because I think he's failed what we would have considered best medical therapy. I mean, best interventional therapy with DCB or drug-coated therapy.
Yep, small vessel as well, a small Asian lady, not too tall as well.
And if he had an adequate vein, obviously.
Yeah. Yes, Lawrence? Would you do an intervention first?
Yeah, and is this post-stenotic aneurysm, is that the site of the previous DCB?
Yep, that's the usual,
Yeah, so I don't know that I would try to do atherectomy in that area. I think the whole area is kind of effed up without using the expletive. And so I think the outflow, you're in olive 2 right now in the
2,
foot?
so it's heel gangrene, AT, reasonable arch, and then...
That heel she needs really good calcaneal
yeah,
flow.
we need to get...
And I don't know that there's going to be a salvage to this, quite frankly, but at the end of the day, I would try to treat this with just balloon if necessary, but you're the surgeon, I'm not. I would think that if you can
Peter?
get down to that foot and there's a PT focus, then that might be the best way to go.
Yeah, Peter, what do you...
I probably would go one more round of interventional therapy, but I echo Dr. Garcia's concerns regarding the flow. It's predominantly AT outflow. The pedal arch is incomplete, and it looks like the perfusion to the calcaneal heel distribution is pretty limited.
It's a pretty bad...
It's a bad situation.
Bad gangrene. So, of course, this is before best CLI, so... No vein graft ultrasounds for sure.
Well, I mean, the reason I'm saying is I think it's wise to get a surgical consult here because, without a question, you've already failed. You've got the DCB changes with the post-stenotic, the aneurysm sort of formation, the dilation, and you've got very few targets. So unless you get a good denial from surgery saying that, hey, you know what, do what you can, I think it's worthwhile to always approach it in that way.
So, I mean, at that point of time, my plan was to maybe do something first. So if I were to do an intervention, if you were to do an intervention for a previous DCB with a spot stent, what would you do if it was an intervention in this case? Would you just stretch it? Atherectomy?
In this case?
Yeah,
in this case, I would 100% scaffold, stent.
Stent, because of the gangrene?
Yeah, absolutely. I want to increase as much flow as possible.
Get a FemPop-like result?
Exactly.
Okay, fine. Okay, so this looks reasonable for balloon angioplasty. So, okay, so what's the plan for below the knee? I thought maybe DS here or something like that. I don't think I wasn't going to do the whole loop and, subintimal dissect the whole thing, but that was my plan. So, okay, reasonable the drug-coated balloon, so that's what I did. Do an angiogram just to see where I should land a drug-coated balloon, pull the bright tip sheath all the way back. 5 mil drug-coated balloon. What do you guys think? Better. And I decided, maybe, the angiogram after the 5 mil drug-coated balloon looked quite reasonable, but I thought there might be a little bit of a constriction around the adductor canal, and I think we'll see there was actually quite a bit of calcium around there, and so I decided to stretch that with a 6 mil balloon post-DIL. right? So this was I believe it was a Mustang or Power Cross, a bit of calcium there, 6 mil balloons. Okay, let me play that, sorry. Again, looking at the proximal, a lot of calcium around, 6 mil balloon. With a high pressure balloon, focal balloon, and then things start to head south now. I'll show you the angiogram. Oops. Okay, well, hang on. Okay, so this is the angiogram. Oh, what's that? Oh. So this is the part where, okay, something's going on. What do you guys think?
What was the ACT?
I can't remember, but this is supposed to be a short intervention. I think I probably would have said send for the next case, which you never say until you pull and you put the closure device in or whatever. So basically this is a drug-coated balloon, 5 mil drug-coated balloon. It looks better, it looks good, but a couple of focal points, a lot of calcium in a small vessel, and I post-dill with a long balloon and a bit of calcium. I said, okay, let's go for a short focal balloon to stretch that post-dill, and I used a 6x40 Mustang. And I get all this. Maybe I can play this again, and you can see what is this. There we go.
And Dr. Kum, in these areas that are now just focal limited flow, any consideration to putting like a drug-eluting stent, a short drug-eluting stent in that segment and then post-dilating?
Yeah, possible. I mean, it's 2017, so at that point of time.
No drug-eluting stent at that point. Yeah. Well,
I'm not sure. Well, there was probably drug-eluting stents. There was Zilver then, but it was the era of leave nothing behind, if you remember that.
Yes.
Leave nothing behind.
The facts behind.
So, okay, so this is like a disaster right now, right? So, in slow mode, you guys are going to see this. Let me just play that back again. So watch carefully. What is that? Has anybody seen this happen? PK, I've showed this case before. You've definitely seen it happen, but you've forgotten. What is that? Okay. I'm sorry? No. This is movement of calcium.
Calcium, yeah.
This is movement of calcium. So this is in the percutaneous arthrectomy, but not in a predictable way. Okay, so what is this? I mean, did you see when I injected the contrast, this thing floated up, right?
Yep.
And it was mobile. So what is this? Is this fresh thrombus? Is it, what is it? So, of course, certainly I did not play the angiogram, and then so my immediate response was, this is probably some form of thrombus. Maybe the nurse gave me saline instead of heparin, as possible, right?
Be a dissection.
Dissection? Yeah. Possible, but this looks pretty mobile. It's like a big chunk of stuff that's floating up and down. So I guess the usual thing is don't send for the next case. What do I do? Do I do a surgical bailout? Do I do thrombectomy? Blah, blah, blah. So of course, first thing I do is I bump up the heparin just in case someone has given me saline. And I pull the sheath back and I do a contralateral approach because I have a pretty tight area here. And what I did was I popped the sheath into the profunda, and I did to image, and then I did a contralateral approach, and then 6 French, and of course, the first thing you do is a rotarex, to try, and it's pretty decent suction. You can see the stent collapsing down, try to suck out, and oh my God, this looks terrible. Okay, I try to clean it out again, and still looks terrible. Any thoughts on that? So the sheath is in the profunda to perfuse it.
If it's thrombus, then you can aspirate it, which is what you're doing, or you can really hedge your bets and put a Viabond in there. That plaque, pacify it, 'cause it plaques it up against the side.
So things start looking very bad right now. I mean, there's like stuff. I probably shouldn't have ballooned it, and
Yeah, I was going to ask, why'd you balloon it?
I probably shouldn't have ballooned it, but I think I was getting a bit stupid then. As you know, as complications go on, what the hell's going on? Like this is a straightforward stenosis, right? So some stuff goes down in the balloon even more, and then things don't look good at all. So there's better flow, and some of this stuff has hit down south. You can see the flow is slow. There's bits of stuff over here. What is going on, right? So.
Well, you do bring up the good question. At that point, when you went contralateral, did you put a wire down with a filter just to protect? I mean, I guess I know what's happening here, but...
Yeah, I think it's a good point. I think that's probably what I would have done.
Yeah, and it seems like it's to and fro, so there's got to be some embolization down here as well. And you don't have a great outflow to begin with.
Yes.
Glad it's your case, not mine. How about that?
So what I do now, there's flow, accept the result, anticoagulate, lyse overnight, stent the whole vessel, surgical bailout, Why is it really getting very hot in here? I'm feeling the heat.
Any idea of an IVUS? Because I still feel that there might be an element of dissection, flap removal, and then it forms a thrombus. So if you IVUS and find there's an entry point, maybe stent that and reassess with thrombolytics?
Well, it seems to be, the balloon angioplasty kind of showed it wasn't a dissection because it seemed to move downstream. Yeah. So, I don't think it's a dissection. I think that one or two things. One, what Lawrence said is, you can cover it from the get-go, especially when it started looking really nasty. Yeah. And two is, you're a surgeon, I'm not, so you could have cut down and done a Fogarty and probably cleaned it out a little bit easier. And I don't know why, that could be a reasonable bailout, but I don't know what that entails.
I don't have consent. It's not consented. It's for a big, bad heel gangrene, so I'm not sure we'll end up salvaging the leg because the gangrene is quite severe.
I'm saying just to clean this out. Right? And then through the cut down, you could have done your stenting or whatever you needed to do.
If I'm going to cut down, I'm going to do a fem-pop.
I see.
Right?
Got it.
And of course, there's a problem also because if I do a fem-pop, I'm going to have competing flow through a patent SFA, patent-looking SFA, and then a fem-pop graft. I have no idea what's going to go on. So normally we do a fem-pop from the occluded SFA. So anyway, it's getting hot, right? So I decided, I have no idea what's going on. It seemed that I've cleaned out a whole lot with the Rotarex. I don't think there's soft stuff, so I decided to stent everything down.
It's getting very hot.
Getting very, very hot. Okay, there's still an outflow problem down below here. So this is a catheter run, but there's a piece of stuff down there that I've already tried to Rotarex and I can't really solve the problem. So I decided, against better judgment, to just put a stent in, and it looks great after that. The SFA, looks good, and then the inflow was still a problem, and they decided to stent the top end as well. At this current point in time, I had to review the images, and I actually realized that because of the high-pressure balloon angioplasty, I had tore the intima, and the calcium had embolized upwards and drifted south. Now, this I've never seen before. I've never had calcium. It's like when we do surgery, we squeeze the plaque out, and there's a breach in the intima. But at the point in time, after this, we had to stent the whole SFA to scaffold the whole thing. It wasn't a soft clot problem, so this is what we had. We still have flow that was chugging down, and I'm quite happy at this point in time that I had a contralateral access, and I could still press, not use a closure device, and image the common femoral. That's quite okay, and I left the patient in the state. Wow. This proximal portion was stented, and at the end of it was stented with a balloon-mounted stent actually. So, and then at the end of it, the flow looked good.
Why balloon-mounted, Steven?
I don't know.
Because that's an area of a lot of flexion, right?
Yeah, there's an area of a lot of flexion, but I think at a point in time, I wanted to land this thing right on, and I wasn't really thinking why balloon-mounted, but it seemed that the whole vessel was bad, and I just decided to use a balloon. I've done this on occasion. I haven't really had a problem with the balloon-mounted stents cracking. As you can see, this is Assurant Cobalt, so this is way before, right, in 2017. 4 months later, we're quite lucky. The vessel remains patent, biphasic AT. I don't see any. So we've stented across the TP trunk and the peroneal artery, which is feeding the heel. So that's bad news. And the heel gangrene. But this patient had a BKA for calcaneal osteo. But looking back, should I have wired through and should I have done the kissing balloon? At that point of time, it was, I think I just wanted to get out of there. But probably it would have been a good option. Maybe just a balloon across and do a kissing balloon rather than put in more hardware. I think at this point of time, the patient had gained some weight from stents, so I think enough stents. So that's one. So the lessons: recognize plug embolism. It's not so common. For those who don't know what plug looks like, when we do a common femoral end atherectomy, this is what it looks like. Prevent plug embolism. Normally, I would use a short focal balloon to really crack that vessel, but sometimes these days I actually use a longer non-compliant balloon to ensure that I get full coverage around that focal piece of calcium and go up with the non-compliant balloon rather than have too short a focal balloon, and maybe that might actually have torn the intima and embolized the plug upwards. Treating plug embolism, this is plug, right? Lysis not going to work. Debulking maybe for some soft thrombus that happens subsequent to the plug embolism, and stenting and jailing this thing down maybe the only endo option available. Of course, there's still the surgical bypass. So in summary, be aggressive when you have to, be conservative, but sometimes it's hard to know when. Always get an extra set of eyes, which in this case I did not because I was getting really tired, and I think that's quite useful to practice in a group. Anyway, shit happens.
Thank you.